Okay, guys, I think that's about 5 minutes. Okay, guys, welcome back. That's about your 5-minute break, and we're gonna go on to the actual core of the session on patient engagement, and kind of coupled with staff engagement. They're pretty much, from a philosophical point of view, the approaches are pretty similar, because staff are regarded as internal customers, your patients are regarded as external customers, and essentially they should be treated the same way. Okay, so the adage that customers come first, I think is a lot of bull. It's actually your staff that comes first. Okay, and if you treat your staff with the trust and respect and ensure they have what they require to perform their functions, then automatically, they take care of customers, or in our case, patients, the way they should. Okay, so we're going to put up the slides. Just let me know if you can see it. Okay, so we've kind of titled it Reaching for Excellence in the Patient Experience. And essentially what I want to do is start by differentiating. So South Africa kind of generally uses patient satisfaction surveys. Now, that's something that we need to get rid of, because measuring patient satisfaction and likewise staff satisfaction actually doesn't help us a whole lot, because the simple reason that satisfaction is a subjective measure, and levels of satisfaction vary from individual to individual based on what their expectation is. But experience is pretty objective, and this is the difference, and it's the reason why we need to migrate from satisfaction surveys to experience surveys. Now, I kind of use the common example is that if you give a homeless person a plate of food, and then you ask them the simple question, were you satisfied with the meal? What do you think the response is going to be? Anybody? So we give a homeless person a plate of food and we ask them, well, how satisfied were you with the meal? What do you think they're going to say? Any takers? Any takers? What would that response be? Sorry? Yeah, I mean, exactly. They're more like, they're probably going to be very satisfied because of the fact that it is relative and it's subjective. And the guy, may not have had a meal in a few days or the day, and anything for them will be satisfying. Okay? So the same thing in healthcare. When you ask somebody who's kind of dependent on the public health system, how satisfied are you with the different aspects of it? It is not surprising that you get scores that suggest that everybody is shockingly satisfied. I think the average satisfaction scores in South Africa are around 80%. And generally the way they measure satisfaction is on a scale of 1 to 5, and then 3 being the midpoint. Anything below and anything above, this is less satisfied and this is more satisfied. Okay, so the average scores in South African public sector are 4. 4 out of 5. And so that's a kind of immediately, it's a warning bell. Because for you, that a lot of you who work in the public sector, you probably have a strange suspicion that's a bit skewed, and you would be right. It's because of exactly the same reason that I gave you, with the case of the homeless guy getting a meal. Because remember what I said to you, value, if you can just go back to the board, Vic, I said value equals quality over cost. Okay? And so people assess the value of what they're receiving based on those two things. If we keep the quality constant, that's your plate of food, and the cost is 0. So Q over 0. Anything divided by 0 is what? If you divide anything by 0, what's the answer? It's what? This is 0. What's the other response? The same?
The same.
Nope, it's not the same, and it's not 0. Anything divided by 0 is undefinable. Did you forget that?
Oh.
Okay, you define anything by 0, it's undefinable. So this is public health care for you. Okay, so it's keeping quality constant. The value, because there's a cost of 0 to the person receiving it. Okay, you can change the cost and put price, it would be more correct. So if you say, you're getting all of this and it's not costing you a cent, how satisfied are you? Remember, satisfaction is part of quality, okay? The answer is undefinable. So patients cannot give you a correct indication of their level of satisfaction at a price point of 0, because in effect it is undefinable. So whenever you receive anything with a 0 price, very difficult for you to place value on it. It's very difficult for you to put a score to what it's worth to you, because if there's no input, if there's no cost from your point of view, then you'll always score high because you don't have that sense of how to define the value. So bear that in mind. This is the reason why patient satisfaction scores in South Africa are high, because there's no price sensitivity, and therefore the score that you get is skewed, because patients don't actually, it's undefined. They can't really define it, so you get those high scores. Okay? Now, this is why it's important to actually use experience as opposed to satisfaction, because experience is tangible. Okay? So if I ask the homeless person, were you greeted before you were given the meal? That's tangible, because he was either greeted or not. That's the difference between experience and satisfaction. We're not asking him, we're saying, were you greeted? Were you explained to, in terms of what the meal comprises? Were you thanked, or was gratitude to you expressed? That's not, are you satisfied? It's actually, did you have this experience with the person? Okay, so that in effect is the major difference between satisfaction and experience. Experience is objective, it's perceptible, and it's true experience. So that's what we need to test, okay? So bear this in mind as we move forward. We actually ask questions. Were you greeted? Where did the person introduce themselves to you? Did they thank you? Did they give you directions in terms of where you should go to? Did they explain what's going to happen to you? Did they ask you what you would like to eat? Did they ask you if the lights should be on or off, or the curtains should be drawn or not? Those are experiences. It's not, are you satisfied with something? I'm asking you, did you experience this? And we can actually, as management and leadership, intervene on an experience score. We can't intervene on a satisfaction score. Because if somebody claims they were not greeted or staff didn't introduce themselves, we can change that. We cannot change a score of 4 out of 5 or 3 out of 5 where somebody is dissatisfied with the experience at reception, because we don't know what to change. Okay, so experience measures are objective, they're tangible, and we can actually intervene on that. Okay, so let's get the PowerPoints going, and then I'm going to walk you through this pretty quickly. Okay, the next one. Okay, so this is kind of giving the difference between the two things as I explained. One is subjective, the other is objective. One is actually, did you have this experience where you're a recipient of A, B, C, D, E? It's not where you're satisfied with it. Okay, so if people have different expectations of something, their satisfaction scores would be different. But their experience should be the same, because you are either greeted or not. That's your expectation is irrelevant. So satisfaction is pegged to your expectation, whereas experience is about your actual encounter. So we need to migrate away from client satisfaction or patient satisfaction and move towards patient experience, because that is something that is objective and something that we can respond to. Okay, now you'll see at the bottom right-hand corner, it says Office of Patient Experience and Engagement. Now this is how important we place experience and engagement, that we actually have its own, it's a department within our health system. And this may shock you because it's staffed by about 20 people. And we adopt a data-driven approach to managing the patient experience. We collect every single patient, whether it's outpatient or inpatient, has to take a survey that may be self-administered or it may be administered by the staff. So the surveys are going on in real time with almost every single patient or the random sample of those patients. It's very important to us because I said earlier on, part of our remuneration is pegged to patient experience scores. Okay, so when we bill the government for services that we provide and our patient experience scores are low, we will get anything from 90% of what we should get and below, because that proportion is at risk based on these metrics. So it's pretty important to us. Okay, so we have a structure and we have some organization to actually get these scores up, and we work on this every single day. Okay, so it's got to be taken seriously. It's not like the public sector mentality we have is, well, patients don't have a choice, so they have to come to us, otherwise they have to go to the private sector. It's just really an attitude that we cannot tolerate, I think, in the public sector anymore. I mean, the perception of the public sector is extremely poor, despite those satisfaction scores being high. Patient experience, I'm sure, is extremely poor. Okay, so I'm actually planning to run patient experience surveys, and I'm pretty nervous in terms of what that will reveal, because I think you'll find a very big disconnect between experience and satisfaction. Okay, next slide. Remember, this is from the Hippocratic Oath for the physicians, the medical guys in the audience, for the social development guys from Northern Cape. It's pretty much the same thing. And what the Hippocratic Oath says, it's not all about the science of medicine. Okay, that we have to understand, in this case, warm sympathy and understanding, outweigh the surgeon's knife or the chemist to drug. So in other words, the science of medicine is secondary to the kind of empathy and that you would show towards a patient. And from DSD, it's towards your client, because that's more powerful, okay? And the data is pretty compelling, as you'll see later on, that patients who have a positive experience are more engaged, and they respond far better, and they're more compliant. Okay? That correlation does not exist between satisfaction and outcome. It exists between experience and outcome. And that's what Hippocrates said centuries ago, is that if you treat people as people, you know, the actual technical medical intervention is secondary. Okay, next slide. So it's exactly the same thing, just a reinforcement of what I said. Go on. Okay, so what creates that exceptional experience for patients? Next slide. So you can see here that when you look at suffering, you can kind of stratify that between what's unavoidable and what's avoidable. And you can see the suffering due to the diagnosis, the suffering due to treatment, and then of course the avoidable suffering due to the adverse experience that a patient may have. It's a significant part of the total suffering that patients endure. Okay, so it's something that you can actually control. You know, you can't really control the diagnosis because the patient is already there. You can, to an extent, control the suffering due to the treatment, sometimes not, but what you can totally control is the suffering from an adverse experience. So, you know, all of this contributes, and you have to minimize this at every level. Okay, next. Okay, so you can see this when you look at data, and this is kind of, you know, why data is useful and powerful, and it's the reason why we need to start collecting data in South Africa. Is there's an absolute paucity of data, which makes kind of decision making and strategic choices very difficult. You can see here that 93.8% of patients said that they're really willing to go out of their way to access an institution where they will have a positive experience. Okay, that's pretty powerful. So they rank that higher than the actual quality of care. Okay, so once again, it's kind of almost reiterating what Hippocrates said, that, you know, how you treat patients is more important, how you treat patients from a humane point of view is more important than the actual technical care that you deliver. You can see that 65% will actually pay more to go to an institution that's highly rated. Now we're looking at all of this in the context of patient experience. Now in the private sector, you know, so in the US, all the hospitals are basically operate like private hospitals. So you get paid for it. But you will get paid to see indigent patients who can't afford it. They get paid, you know, the government pays for them. So we have a national insurance, although that's not what it's called, but that's what it is. And this is where the NHI is going to kick in. And if we start asking these questions, you'll see patients will probably say the same thing, that they are prepared to go to a hospital where the experience is better because to them that's what's important. They can place a value on the experience. They really can't place a value on the technical quality of the care they receive because they don't have the skill set to assess and evaluate the technical quality of the care. So if you take a simple case like for a patient going to get an ECG done, the patient doesn't know if the procedure followed is the accurate procedure to do the ECG. Okay, they don't know. They don't know whether the ECG was accurately read by the cardiologist or the physician. They don't know that. What they know is what they experience. You know, how were they treated as individuals? They can score that and they can assess that and they can evaluate that. And all of this data shows that those things are important and patients place a value on that. And I think this is going to become extremely important as we transition towards an NHI. Okay, next slide. Okay, so the future is also patient engagement. Remember, satisfaction is not experience and vice versa. Patient experience is not patient engagement. Okay, so highly engaged patients will be patients who have a positive experience. Patients who have a positive experience will generally be satisfied. It does not work the other way around. So bear that in mind. An engaged patient is somebody who participates in the care. They're engaged, they're active, they're compliant. They're actively engaged. That's what this means. So generally, patients who are engaged are more compliant. And from a healthcare point of view, it's kind of the ultimate case. Is we want an engaged patient who participates in their care and actually who's an advocate for their own care. That's what engagement is. So a highly engaged patient advocates for themselves. A totally disengaged patient, attributes their care to their physician. So a disengaged patient says, well, that's my doctor's job to look after me. A highly engaged patient says, well, it's my responsibility to take care of myself. That's why engagement is so important to us. And that's kind of why it's something we want to encourage. One of those levers to get engaged patients is the positive experience, okay? And essentially, we'll spend the next couple of hours talking about, well, how can we actually improve that patient experience? Because the goal is engagement, as I said. Engage patients, advocate for themselves. Okay, next slide. Please stop me if you have any questions, okay? We don't have a lot of people on, so we'll still be able to get through this pretty quickly. Okay, so any questions? Yeah, go ahead. Just put up your hand in the chat and Vic will let me know. So you can either type in your question and I'll respond, or put your hand up and ask, and Vic will come back to you to ask you. Okay, so do patients and consumers expect the same things? So, consumers, traditionally are people that would be purchasing a product or a service in the traditional market sense. Patients are somebody who access care delivery in hospitals. And historically, those who access care, we define as patients, and those who purchase just general products and services are consumers. And the question is, are their expectations the same? Okay, next slide. And what you'll see is, the answer is yes, because a lot of what patients want is exactly what customers want. They want a positive experience and they become more engaged. So in a business sense, you can see a lot of massive global companies differentiate themselves based on service and based on the customer experience. Now, Starbucks is a very good example because all they sell is coffee. Their product is coffee. And I can tell you, there's nothing really special about their coffee. You can get exactly the same coffee, those beans that they use in Pick and Pay and Woolworths and all of those stores, and same with their coffee. In fact, you can walk into a supermarket and buy Starbucks coffee that you can make at home. How have they differentiated themselves in the store? because they have optimized the customer experience. They make the customer feel special. And they have kind of revolutionized the sale of coffee. So this whole concept of the coffee shop has its genesis in Starbucks. Because they took a normal product and they created an experience around it. The fact that you can now come into a store and sit down, order 10 different types of coffee, you get this aroma of coffee in the air, it's a pretty cool place to be. That's the experience. Okay, and all of the companies that I listed here, some may be familiar to you, but not. The Ritz-Carlton is a hotel, pretty famous hotel, differentiated once again by the experience. Okay, this is what differentiates these companies. Same with Amazon. There's several of these e-commerce companies around, but Amazon continues to grow and get better and better because they just offer a better online experience. It's much better for you to get information, to purchase the product after sales, etc., etc. So the point is that it's exactly the same concept that should apply in healthcare, because patients are also customers. Patients also go to Starbucks, and they also go to the hotel, and they also go to McDonald's and all of those kinds of things. So, their expectations are the same in both contexts. Okay? Next. So, I guess, if we have to ask you what you think about the experience that patients have in your organization, I'm not sure how you would perceive that, but let's just ask the question. Anybody what do you think of the experience in your hospital organization? Is it something that you're proud of? Or let's reframe it. Do you think there's room for improvement as far as the patient experience goes in your organization? Room for improvement, yes or no? Hello?
Yes, there's room for improvement.
Yes. Yeah, I would think, by the way, in quality and safety, there's always a gap. Okay, there's always a gap. So whether you're looking at patient experience or whether you're looking at safety, by definition, there's always a gap that you need to address. Okay, so from my experience in the South African public sector, I think there's room for significant experience, as you'll see as we move on. Okay, next. Next slide. Okay, so we've discussed this. This is the expectation as far as patients in terms of, so this is the value proposition of healthcare. Remember, this is the defragmented 6 things, but we've added the 7th, a positive staff experience. And ironically, you'll see that data suggests that where a positive correlation between staff experience and patient experience. Okay, where the staff have claim to have a positive experience, the patients tend to have a positive experience, and outcomes. Health outcomes and non-health related outcomes are both positive. Okay, so hence I said that we should change the safe to staff engagement and put the safe right at the end, because if staff have a positive experience and are engaged, then kind of the rest becomes much easier. Okay, next slide. So we've covered that. As you can see, data once again showing that positive association, as I said, between patient experience, patient safety, and clinical effectiveness. So where the patient experience is positive, the safety and metrics and clinical outcomes are positive as well. So, and this has been demonstrated by several studies actually. In fact, some of those readings that you have reinforce this. So my point is, there's a logic and there's a rationale to focus on patient experience. Because one, it improves clinical outcomes, and 2, it actually improves the business outcomes. Now, in the public sector, remember, you still have budgets to work within, etc. So in effect, there's a business component to it. So it has positive clinical outcomes and it has positive business outcomes. So there's a logic and a rationale to put patient experience, front and center of your organization. And as I said, that's the reason that we have this Office of Patient Engagement and Experience. We do that because our patients do better clinically and our organization does better from a business point of view. Okay, so it makes sense to invest and allocate resources to this. The average allocation, budget allocation to patient experience should be around about 0.5 to 1% of total revenue. That's what you should do. So if you have a budget of 100 million rand, you should allocate at least 1 million rand of that towards investments in patient experience. Okay, so kind of very rough number, but that's the way I look at it. Okay, so at least 1% of your revenue should be invested in managing the patient experience. Okay, so next slide. Okay, this is once again a study by Deloitte, and you can see it's this pretty much the similar theme coming forward. Rationalizing the logic and reason for investing in optimizing the patient experience. So just more data and more studies to support that. Next. Okay, from a people and process point of view, so once again, this is another study that I found very useful, that I think you will find useful as well. If we have to look at how patients value people-related components of the experience and process-related, I think it'll be self-explanatory. Next slide. So you can see in this slide what the highest ranked patient experience components are. And you can see the overwhelming majority of these components are actually related to people. And people, in this context, is your staff. So do you get a sense that, the doctor or the nurse or the receptionist actually listens when you talk to them, okay? So 95% rated that as being important. Do staff communicate in a clear way that you can understand? 95% of that reported that's extremely important to them. Now, this is extremely important in the South African context because what we see increasingly is kind of the diversity increasing amongst our provider group. With a lot of foreign professionals now working, and that, by the way, is a really good thing, and we're grateful to them for that. But there's an issue, or maybe a perceived issue, in terms of communication and the ability to understand. The ability to communicate in ethnic languages may be compromised. So this is an experience issue. But it's a pretty important issue because you can see patients value that. They value that extremely highly. So you can see a lot of these people-related components are very highly ranked, and some of the process components, like the ability to make an appointment, issues related to access and the discharge process, are also ranked very, very highly. So it immediately gives you a sense of these experience measures that are important to patients. And sometimes, we have a sense that the only thing that matters is the technical quality of our care, the extent to which we address a patient's medical condition. Well, from a patient's point of view, as I said, that's not necessarily the thing that's most important to them. Because frankly, they're not in a position to evaluate the technical component of that. Okay, so bear that in mind. Next. So the patient improvement, the patient engagement or patient experience improvement cycle is pretty much the same thing we covered in the, in implementation of solutions. And I said, the couple of tools you would have learned, PDCA, DMAIC, all of those. So the process of that is pretty much the similar. Okay, listen, identify the problem, listen to the people, conceptualize solutions, implement, monitor, check it. It's pretty much the same thing. Okay, so I'm not going to spend any time in there. You've been through these improvement processes. They're pretty standard, and it's in your book as well. Okay, next slide. Okay, so you can see in this study where we looked at doctor-patient communication, and some of the barriers in this case was in the pediatric context. You can see some of the issues that patients have raised as it pertains to doctors and some of the providers. So the number one, from a pediatric patient's mother's point of view, lack of warmth and friendliness in the part of the care. Failure to take into account the patient's concerns and expectations from the medical visit. So the one thing we never do as a physician, I'm probably as guilty about this as I know a lot of my colleagues are, we actually never ask patients what their expectation of the visit is. So what do you actually aim to achieve by the end of this consultation, by the end of this visit to the hospital? What do you actually want to achieve? And if you ask patients that very simple question, you can ensure that you check the box and address their key issues. Now, this is what patient-centric care is asking the patient what they want to achieve and addressing that. Not as a physician or nurse, you do what you think is best for the patient. Okay? It's kind of crazy, but it kind of makes sense. We should ask them, whether the patient is an inpatient or outpatient. Care delivery is not patient-centric at all. Care delivery is provider-centric. It means we design the whole care delivery process based on us, physicians, nurses, and hospitals. And claims of patient centricity are hogwash. The reason that we get patients up at 5 a.m. every morning to shower and have breakfast, that's not being patient-centric, that's being staff-centric. The reason we get them to do that is because it suits our shifts. Because we have nurses changing shift at 7 o'clock and everything has to be sorted before that. That's not patient centricity. Okay? Designing all of that based on what the patient wants, what time does the patient prefer to get out of bed, what time the patient prefers to shower, what time the patient prefers to have breakfast, that's patient centricity. Okay? So you can see to become patient centric is going to require a radical rethink of how we do things. We've got to revisit the whole care delivery process. I use the airline industry also as an example, of not being fully customer centric. For those of you who are lucky enough to fly, whether it's often or not, in the old days, we used to get meals. I think in some flights you still do. But anyway, it's pretty regimental. When the flight reaches 10,000 feet, they wheel out the trolley and they give you a drink and then they give you a meal and then they pack everything away. They go and sit down and, they may offer you something there. But that's a case of not being customer centric. They give it to you to suit their schedule and to suit the way they've planned for that flight. Okay, but what you see now is some airlines actually breaking away from that, is that you can decide when you want something to drink and when you want something to eat, and all you have to do is give them a 5-minute lead time to prepare that for you and bring it to you. Okay? Now that required a radical rethink of how they plan and organize within the planes. Okay? So for us to claim that we're patient-centric, we've got to look at all of these things and design care delivery based on what patients want. Okay? So it's a pretty onerous task, but we have to do that. Okay? And we at UAB are doing that now, thank God. Okay? So lack of clear explanation concerning diagnosis. You know, we often don't do a good job of explaining to patients in their own language and in what they understand in terms of these two things, the causation of the illness and the kind of diagnosis and issue. The other issue that comes up is use of medical jargon, also a kind of default position for us. So these are 4 things that are highlighted, and I guess, you know, when it comes to pediatric care, it's even more important because, you know, these are mothers' responses and time we listen. Okay, next slide. So you can see, again, the positive correlation between positive patient experience, and empathy is a component of that positive experience. And in this case, diabetes control, okay? Diabetes and cholesterol. Your LDL is cholesterol, the A1C is diabetes control. And you can see the positive correlation between patients who have a positive experience and their diabetes control and their cholesterol control. Because remember what I said to you, experience leads to engagement. Positively engaged or engaged patients are patients who advocate for themselves. So they will be more compliant, they will be actively participate in their care delivery, and it's not surprising that their disease control will be better, whether it's diabetes, hypercholesterolemia, whatever else you may have. Okay? So it's the same point that we're emphasizing and reiterating. There's a business case and there's a clinical case to be made to enhance the patient experience. Okay? So, and remember, non-compliance is a leading cost driver in healthcare. So these patients that flood your outpatients and flood your wards, if you collect the data, you'll realize that a lot of them is because they have not been compliant. You know, diabetics not compliant, landing up in hospital, you know, with complicated diabetes. Hypercholesterolemia patients who historically not compliant land up with cardiovascular disease. So hypertensive, not compliant, cardiovascular disease, strokes, etc. So if you do an analysis of all inpatients who drive a lot of the cost, at the root of that is they have been non-compliant. Okay? Non-compliant, which you can probably attribute to being poorly engaged, which you can probably attribute to having a poor experience, and probably attribute to low levels of satisfaction as well. Okay, so you know, once again, making the point that I have been from the beginning, that there's a good case to focus on experience and engagement. Okay, next slide. Please stop me if you have any questions. Okay, so put up your hand, just stop me and ask the question, and I'll be happy to take it. This is a kind of quotation from a physician. It's kind of, you know, the issue that we all experience. Many of us have to be decades into our practice before we attend this course on, well, how do I actually improve the patient experience? Okay, so if I ask you in the audience, I'm sure for most of you, this would be the first time. You know, you graduated from medical school and nursing school years ago, sometimes decades ago, sometimes several decades ago. But it's only now that you do a course on how to optimize the patient experience. It's only now that you get the tools to address that component, which is an important, once again, predictor of health outcomes. Okay, so the irony of it, you know, is we base medicine on Hippocrates, and it's actually Hippocrates that was the guy who said that it's not the technical aspects of medicine that determine the outcomes. You know, it's the humane aspect of it. So it's kind of a dissonance in our profession, but that's another discussion, I guess. Next slide, Vic. Thank you. Okay, so as I said, I'm going to discuss 3 tools with you. The one is rounding. The second is managing up. And the third is ADET. 3 tools. Okay, so these 3 tools will hopefully lead to a positive experience, and that hopefully will lead to engaged patients, and that hopefully will lead to positive clinical or better clinical outcomes. Okay, so 3 tools. I'm going to go through each one of these briefly now, and then I have slide decks for each one of them, which will kind of get more granular, but you'll get all of these slide decks. And what you'll find is it's pretty self-explanatory. But this concept of rounding, I think, is one of the most important concepts that is highly positively correlated to positive patient experience. Now, rounding comes from these clinical rounds and ward rounds that we do in the hospital. So for the social development guys that are on today from Northern Cape, I mean, you probably, if you've had an interaction with the healthcare system, you know that nurses do a ward round at 7 in the morning, when the doctors come in at 8, 9, 10, 11, 12, or whatever, they do a ward round, and they do one in the afternoon. And essentially those ward rounds are medical rounds. They do these rounds to optimize the care delivery. Okay? And what we are saying that you now have to round to improve the patient and the staff experience too. So the principle is exactly the same. But the purpose is not adjusting treatment or trying to ascertain diagnosis. The explicit purpose of rounding in this case is to improve the staff experience if you're rounding with staff, and to improve the patient experience if you're dealing with that. So once again, the same principle applies. You know, it's impossible for you to round with every patient or every staff member every day, but you know, you can do a random sample of patients, and from a staff point of view, you've got to get through everybody at least once a month, depending on the number of staff that you have. So rounding is important. Now rounding, okay, let's just go to the next slide, Vic. Rounding is a very specific process. You know, as we say here, it is proactive. It's about going out and engaging the patients or the staff, listening to them, and the whole point is learning from them. You know, about what can you do to meet their expectations. If it's about staff, what can I do to support you, to help you perform at your best? If it's patients, what can we do? What is your expectation from us, and what can we do to improve your experience with us? Okay. Now you can see we've also included here patients and families. So it's a pretty good idea. Now the previous data I showed you were pediatric patients, but for obvious reasons there, the mother was interviewed. But, I think you get a pretty good sense of the experience from a family point of view as well. So not only is it employees, is it staff, physicians, nurses, and patients, I think you should do a random sampling of families as well and round with them. And as I said, in this context, rounding is very structured, it's very organized, it's scripted, like everything should be. In healthcare, we're a very haphazard profession. We want to kind of introduce this element of standardization, even in the way we communicate in healthcare. Okay? So even your rounding, the questions are all scripted, and you ask every single person the same question as well. So more on that later. Next slide. Okay, so just a couple of bullet points is essentially this is what the purpose is of rounding. Essentially, it is to explain what what the hospital is there for, what's the purpose of the hospital, what you stand for. The purpose is also to manage up your staff. Now we'll come to managing up, but so rounding is generally conducted by hospital leadership, and this may be unit heads as well. And one of the reasons you do that as well is to manage up your staff. In other words, speak highly about the competence and experience of your staff members. It's the opportunity of a lifetime to communicate to the patient the technical skill and ability of your staff. And so although patients, as I said, don't have the ability to judge the competency, the clinical competency of their physicians or nurses, but this is something you can do during rounding. And what we call it is they develop a sense of competence by proxy, meaning the patients get a sense of the competence of your clinical staff during rounding when you manage up your staff. You talk highly about their qualifications, their experience, their good outcomes with similar cases, etc., etc. That's the concept of managing up, okay? And this is a critical leadership tool, is you have to manage up. If you want people to become self-confident, become engaged, improve staff engagement, increase patient, you got to manage up, okay? So don't run down your staff members or your colleagues or your team. Always manage them up, okay? Okay, so reinforce the actions that support the provision of hardwired behavior. You want people to, so if you compliment somebody on their behavior, what happens is you reinforce that. So that's something you can actually do during rounding is if somebody has done the correct thing, you compliment them and tell them to continue doing that, and that hardwires the behavior. It becomes second nature, okay? And connecting staff back to purpose, that's important. And then proactive service recovery. So some of the reasons I think pretty self-explanatory. Next. Okay, so we're going to come to, so this is kind of the technical approach, but you can see it's acknowledgement, introduction, duration, explanation, closing, thank you, etc. Recognition, all important. We're going to come back to that Excel. That's what I referred to when I spoke about ADET. Okay, it's also a tool. We'll come back to this. Some of you may have heard it. I've introduced these concepts in some provinces already, and it may have filtered down to you because I know your HODs have been through this program, and hopefully they've been communicating this to you even before today. But ADET, and we're going to talk more about that, is a formalized approach to communication with staff and patients. Okay, we script this And essentially that's what the slide is talking about. I'm going to come back to ADET. Next slide. Okay, these are some of the key words. You can see on the right-hand side, one of the reasons is to reinforce the behavior and articulate the reason for being. Remember, this is the purpose of your organization. So you've got to constantly reinforce what you stand for. Remember, purpose is reason for being. You know, what is the purpose of our organization? What is the reason for our being? And you can frame that in the context of steeps if you want to, or value, etc. But it's kind of, you know, an approach to doing this: knock on the door, address by name, and ask for permission. Okay, so this is if you're seeing a patient, if you're rounding on a patient who's in the ward, or if you're rounding on a staff member. Okay, address them, provide them with your name, title, experience. I would like to spend a few minutes with you. Our goal is to provide you with excellent care. How well are we doing with this? So this is rounding with a patient in this case. Thank you for your time and feedback, and I'll share the feedback internally with staff, etc. So it's some key words that you have the slides, but it's one way in which you will write the script. So if you're going to start rounding, the first thing you're going to do is start writing the scripts, because you've got to formalize this communication process. You know, write down the script, plan exactly how you're going to do it, because if you have the scripted, standardized approach to approaching patients and staff, and you ask them exactly the same questions, then you collect data points that you can actually aggregate and analyze. If it's haphazard, not structured, everybody around with gets a different question, you're not going to be able to draw inferences or conclusions that's going to help you to change anything. So please bear that in mind. Next slide. Okay, so some of the things, I mean, one of the things you're ascertaining is just to what extent are you meeting their expectations? So maybe you can start off by asking them, you know, what do you really want to achieve in this visit or in this stay? And then, you know, you can write it down next to the patient on the whiteboard, A, B, C, D, and, you know, as you meet those expectations, tick it off. So patients can see that you're actually patient-centric, that you're working towards achieving what their expectation of that visit is. Now, as I said earlier on, we don't even do that. We don't even ask patients what their expectation is. We assume that we know what the patient really wants to achieve in the visit, okay? So some things you can ask in terms of how well you are doing, in terms of keeping you informed, keeping your room cleaned, explaining the test results and treatment, explaining what will happen after discharge, managing your pain. Some of the key important questions that we ask our patients. Our office sends people around, and these are some of the things we ask them, okay? Now you can see here, it is, we're not asking you how satisfied you are. We're asking you, are you being informed? Is your room clean? Are we explaining to you what your test results show? Are we explaining to you what your treatment entailed? Okay? Did you get discharge instructions? Nowhere here are we asking you, are you satisfied with anything? Now that's the difference between assessing experience and satisfaction. Okay? So once again, you know, you got the material here to develop that script to assess that. Okay, next slide. Once again, as I said, round on the staff first. So as you're planning to use this tool, which is rounding, you know, start with the staff, because as I said, everything else depends on a positive staff experience. So start with them, and if you're doing it for the patients, know the patient's name. So before you enter the ward, make sure you have the patient's details, And you should, because you would have chosen your sample of patients for that day ahead of time. So, you know, you can have a sticker with you on that questionnaire or whatever it is. But know the patient's name, set the time expectation up front, you know, give them a sense of how long you'll be. A reasonable rounding time should be around 10 minutes, okay, or even less. Focus the patient on the positive. Remember, this is all about managing up, okay? Be positive. Be positive about your hospital, your organization, your staff. Because what you're trying to do is develop this competence by proxy. Okay, this is that one-on-one interaction that you have, and share whatever you have with the staff. So, you know, this is extremely important. So if patients speak positively or negatively about staff, you need to communicate that to them. The whole point of rounding is that you're doing it and you're communicating to your staff. And I think if you aggregate all the information that comes from rounding, you can make some inferences and conclusions from that, okay? So just tips on rounding on patients, but remember, round with staff first, okay? Next. Do you have any questions?
Sorry, Prof.
Yeah.
Sorry, Prof.
Yes, go ahead.
Prof.
Yeah, I can hear you.
Just so we're clear,
Yeah.
we're talking about hospitals in the US and
No.
how we improve patient experience.
Yeah.
This is what you say that the hospitals, like for instance in SA, should be doing.
Yes, that's what I'm saying. We don't do it.
Because my thinking is that, look, I'm following and I'm thinking, wow, I've never experienced this thing at all.
Yes, exactly.
Asking myself, how are they doing? Because my experience, you hardly meet management.
Yeah.
As a patient, myself, I've never seen management
Yes.
coming and asking questions.
Absolutely. Absolutely.
It's around itself, particularly because I was a bit confused in terms of the rounding, in terms of the doctor
No.
versus brief.
This is different.
And so
This is different.
this is different.
This is different.
You're already involved in the conversation.
Yes, you are rounding to get a sense of to enhance the patient experience. You're rounding with the patient to find out what the patient expectations are, to impress upon the patient how good your staff is, to understand what you're doing well and what you can do to make their stay pleasant. You know, so this is what rounding is. So it's rounding in the context of the patient experience, not medicine. It is not done in South Africa, full stop. But that's why you're taking this course, is to start stuff like this. Now, we do it in the US. We round patients for non-clinical stuff to ask them about, well, how's their stay going, etc. What can we do? What are we doing right? What are we doing wrong? Are we meeting your expectations? About the hospital stay, about their experience. That's what we're rounding for. We're rounding with staff to do the same thing, and we're rounding with families. We don't do that in South Africa. You know, so these are new tools for you. Okay? But good question. Sorry if there was confusion. Yeah, we don't do it. So if you are in a management or leadership position, this is something you have to go and start doing. Now we'll come back to you and give you specific scripts and examples of rounding, but this is just the overview part of rounding. It's essentially you're round with three categories: the patients, the staff, and families. The purpose of rounding is, you know, from a patient point of view, the things we've discussed, from a staff point of view, things we will talk about, but essentially, what can you do as a manager or leader to ensure that they do their work better? You know, what do they need, etc., etc. What can you do? And you have to round with every staff member every month. The families, exactly the same thing. Take a random sample of families and talk to them about, you know, it's an opportunity to manage up, to speak positively about your unit or organization. More importantly, it's an opportunity to hear from them what you can do to increase and improve the experience as visitors and for whoever they have in the hospital. Okay? Does that clarify it?
No, it's clear.
Yes. So when you get back tomorrow, this is what you're going to have to do. So that's tool 1, rounding. So the term might confuse you, but it's not medical rounds. This is rounding for patient experience. Okay? The second tool is this, is AIDET. A-I-D-E-T. This is a scripted communication tool. And using this tool, often reduces anxiety on both sides, from the provider, from the nurse, the physician, and also from the patient point of view of the staff member, because it's, we're giving you a structured way to communicate with somebody. And this is called AIDET. As I said, it's a simple acronym, it's a powerful way to communicate, and works very powerfully in the healthcare context. And healthcare and social services are essentially relationship businesses. The products are two different things. Okay? The care delivery and the social services are different. But at its root, these are both relationship-based businesses. AIDET helps to build that relationship. Now, AIDET is positively correlated to a positive patient experience. Okay? Positive patient experience, remember, has patients who are engaged. Engaged patients have better outcomes. So AIDET is another powerful tool. Rounding improves patient experience and staff experience. That improves staff engagement and patient engagement. And that results in better clinical outcomes and better business operations. Okay, so there's a logic to use rounding. There's a logic to use AIDET. Okay, so this is just an acronym. Next slide, Vic. Okay, the A is to acknowledge. So this is the first thing you would do. Okay, we have the 5 or the 10-5 rule. Greet people with a smile. Generally, you would greet somebody when they are 10 meters away. You would acknowledge them. This will be non-verbal. So when somebody is 10 feet away, you acknowledge them non-verbally with a nod or a smile. Now, why we were never taught this in medical school and nursing school or at university if you're in socials, I don't know. But it's a critical competence that we never teach to people. How do you actually communicate to patients in a structured way? Kind of beats me. But anyway, so at 10 feet, you want to acknowledge somebody with a nod, with a smile. When they're at 5 feet, so 10 feet, you said, Vic, was how many meters? 3 meters?
Just over 3, yeah.
Yeah, so 10 feet is just over 3 meters, 5 feet obviously 2.5 meters. So you can judge this. Now, frankly, you have to practice this. So you have to measure out in your home what 3 meters is like, so you can develop a sense of judgment of where 3 meters is when you acknowledge somebody. Now, this is not just for patients. You could use AIDET for anything. It's just a communication tool. But it's a communication tool that helps develop good relationships. Okay? Now, if you go into McDonald's or KFC, or you check into a hotel, you'll realize they are pretty much scripted. So you go to any McDonald's, whether you go to McDonald's in Johannesburg, Cape Town, Durban, wherever it is, the script is almost the same. Okay? Pretty much the same thing, the content-wise. They may, adapt it, and you can certainly do that with AIDET, but the content is exactly the same. So you can just press the key there. It's coming up. I think it's the screen. Okay, so as I said, at 10 feet away, you want to acknowledge them, and then use their names if you know. So if it's somebody that you know, use their names. remember, first impressions really do matter. So acknowledge them at 10 feet. When the person is 5 feet, it's good morning, good afternoon, Ms. Jones, we've been expecting you and we're glad you're here. It's a routine greeting. Now, a couple of things here. The name is extremely important, okay? You can see we've been expecting you and we're glad you're here. There's a sense of positivity, encouragement, and kind of almost conveying this message of happiness that somebody has chosen you. Don't look pissed off because they've come to the hospital. You know, that's kind of very often the first impressions that we give people. So I want you to write that script. You know, how would you acknowledge somebody? What are those kind of key words you will have there that you can standardize? And, you know, I've given you nothing. Good morning, good afternoon, Mr. Smith. Welcome to Albert Luthuli Academic. We want to make sure your visit is convenient as possible. Would you please take a moment to confirm that we have the most current information? So this is acknowledgement. Okay, you're acknowledging the other person. That's ADET. A. It's acknowledging. And these are different kind of content regarding acknowledgement. It's about that person. Okay, next. The I in ADET is an introduction. This is an introduction of yourself. So you acknowledge the patient, you introduce yourself, okay? Politely tell them who you are, how you're going to help them, escort them to where they're going, rather than pointing or giving directions. This is important, okay? We commonly will tell them to just, you know, walk down the passage, follow this line or that line, turn left, turn right, knowing very well that it's highly more likely than not that the patient will get lost, okay? This is also an opportunity to kind of put the patient at ease in terms of you being the right person to help them. Remember, they have no way of assessing your ability. So when you introduce yourself, you also want to make note of, you know, not just what your name is, but your qualifications and experience and expertise as it pertains to their condition. Okay, so my name is Susan. I'll be conducting your test today. I'm a certified ultrasonographer and I do about 6 of these procedures a day. The doctors say that my skills are among the best. Do you have any questions for me? Okay, so can you see what's happening here? Immediately, that anxiety that patients have is alleviated because what you're conveying to them very early on is, you can trust me because I do this often. I have the requisite experience and qualification, and my colleagues think very highly of me. So this is not showing off, it's not boasting. What you're trying to do is improve the patient experience using ADET. That's what you're doing, okay? We don't do this. You'll never find this structured communication approach in healthcare, okay? So it's a tool that I want you to use. And there's different, Mrs. Skeepers, you'll be seeing Dr. Glomo today. He's an excellent physician. He's very good at listening and answering patient questions. You are fortunate that he is your physician. So this is if you're referring them on. Now you can see, this is a classic example of managing up. Okay, so you're speaking highly of your organization and the people that are there. Okay, it's extremely important. The patient is then bound to have a positive experience. Okay, so it's critical. And, you know, this stuff is, to hardwire this, you're going to have to write it down. And you're going to have to learn it. And you're going to have to practice it. It's the only way that you're going to get it right. The same way that before you worked in McDonald's, they give you a script and test you whether you know that script or not. Now, how is it that we in healthcare don't bother to teach our trainees this, when this is essentially the business we're in? We're in a relationship and we're in a communication business, but we never teach them this, okay? So Mr. Shabalala, Dr. Gumede would like to see you to have an X-ray in our radiology department, would like you to have an X-ray in our radio. We have an excellent team of radiology technicians who use state-of-the-art equipment. I'm confident that you'll have a great experience. So when you send a patient to an X-ray or to the lab, you don't say this. You fill in the form, you give it to them and figure it out. Okay? And I can ask you now, so when we're measuring patient experience, okay, when we're measuring, we're not saying, are you satisfied with this or satisfied with that? Go back one slide, Vic. So when we're assessing patient experience, we are asking the patient this. When you walked in, did the security greet you? Did the security smile? When you went to reception, did the receptionist greet you? Did the receptionist smile? Did they, use your name? This is how we assess patient experience. Now, the patient is going to answer yes or no. Not, yeah, I'm satisfied, very satisfied, moderate. That's not, because we can't act on that. If nobody is greeting you with a smile, I can act in that. I can change that. Okay, so this is how we measure it. We can use ADET to also measure experience. Next slide. So we asked them about where you adequately acknowledged. Did the clinician, the provider, the nurse, doctor, social worker, etc., introduce themselves with these things? Did they give you their name? Did they tell you about your qualification? Did they tell you about their experience, their relevant experience? That's experience. That's patient experience. It's not satisfaction. Did the patient encounter this? Okay? So I hope you're getting the sense of satisfaction and experience now, because it's, we're using ADET to also bring home the point of how you would assess and evaluate experience. Okay? Now you can see that's distinctly different. Okay? Traditionally, rate your level of satisfaction with the reception from 1 to 5. That's not very useful. Okay? But did the receptionist smile? Did they greet you by name? Did they introduce themselves? That's experience. Okay? So, ADET A, acknowledging the patient. Introduce yourself. Use this as an opportunity to manage up, instill confidence in the patient, in yourself, amongst other things. Okay? Scripted. Script acknowledge, script introduction. Your introduction. Good. Next. That's AID is duration. You have to be very respectful of patients' time. We in healthcare, especially in the public service, have total disrespect for patients' time. We assume that if a patient comes in there, they've got the whole day to wait, they've got the whole day to consult with you, and time to them is irrelevant. But time is important to everybody. So the duration is something we build into the communication. So you really have to keep people in touch with the waiting times, let others know if there's a delay, how long it will take, or how long this kind of service will take, etc. So that's extremely important. Okay? Keep them updated with regards to time. And you'll see the difference that it makes with patients. You'll find patients don't mind waiting. But what pisses them off is when they're not informed about how long it'll take and why there's a delay. Now think about yourself. Think about yourself and how you get pissed off. Okay? If you go to a restaurant and you sit there and nobody comes to you, or if your food is delayed and nobody comes to you with an explanation. Now, you really won't mind waiting if the waitress comes to you every few minutes and updates you in terms of what's happening, what is the cause of the delay, how many minutes it's going to make. That's fine, because all you do is order another drink and carry on, but it does not adversely affect that experience. But making you wait without keeping you informed is what leads to that adverse experience. So if you don't want that to happen to you in any other context, you shouldn't have that happen to your patients who come to see you. So duration is important, even when you're rounding with staff and with patients. Remember, tell them, this is just going to take 10 minutes. Both for staff and patients, because it's important to know. Time is important to everybody. And that's why we build it in to this communication script. Okay, here's another example. Dr. Vilakazi had to attend to an emergency. He was concerned about you and wanted you to know that it may be 30 minutes before he can see you. Are you able to wait, or would you like me to schedule an appointment for tomorrow? Okay, so this is duration. And it's a good example of duration where a patient is waiting for another physician. Okay, but you can see that if this is the communication approach, patients will most likely wait, and they'll understand, because they understand that emergencies come up in the hospital context. They understand that. So they will wait and they won't get pissed off. So don't take people's time for granted, please, okay? Build it into your communication strategy, build it into your script. Okay, any questions so far in terms of the first three components of ADET? So ADET has to become second nature to you, okay? This is something that we want to, every single person at every single hospital or social development unit has to use ADET. They have to, non-negotiable. Okay, that's something we want. Every leader has to round on staff, on patients and families. Non-negotiable from now on. You have to do it. Okay, next slide. Explanation is the E. Acknowledge, introduce, time, duration, and explanation. What is going to happen? Okay, we just carry on with the medical assessment, or we write out forms and just tell patients, go around the corner or go to that room and sit down without explaining, okay? So we really want in the explanation to explain what you're going to do, how these procedures work, who to contact if they need assistance. So it's pretty important, talk, listen, learn. Make time to help, to ask if there's anything else you can do. You always end up with that explanation part of it is there anything else I could do? Or you could put that towards the end when you thank the patient, okay? So a simple example is the test takes about 30 minutes. The first step is drink the solution, and we'll have to wait 20 minutes before we take a blood sample. Would you like to read while you wait? That's an explanation, so the patient knows exactly what's going to happen. If a patient walks into a consulting room, you have to, of course, acknowledge, introduce yourself, tell them how long it's going to take approximately for your consultation, and explain to them the process. I'm going to get the history first, and then I'm going to do some a clinical assessment, evaluation in language the patients can understand. And then based on that, I'm going to decide whether you need an X-ray, a blood test, any further investigation. And if not, what I'm going to do is give you a prescription to go to the pharmacy. So you've explained, the patient is sitting there, you have not started, but you've outlined exactly what you're going to do. Okay, so that's the explanation part of it. Okay, always in the explanation or somewhere in this ADET, you have to make a promise. Make a promise that you will, a promise of excellence. Okay, so bear that in mind. You want to make a promise of excellence. That builds into your introduction. When you have spoken about your experience and expertise, you've spoken about your organization, but make a promise of excellence in terms of what the patient can expect. Because when you make that promise, it also pushes you and your organization to deliver on that. Okay? And it's simple. We promise you that we will do the best for you. And don't just say it. You then have to strive for that. So I kind of call it the ADET plus approach. The plus being that promise. Always infuse a promise into it, and always, is there anything else I can do for you? Okay, this is a script. You have it, this is what it is, and create that script. And finally, it's the T, which I think is self-explanatory. Next slide, David. Is thank you. Okay? Thank somebody, be appreciative. Thank people for their patronage, help, assistance, and even though you're in the public sector, thank them for choosing you. Despite them may not be having a choice in ending up with you, but this is about, remember, it's about optimizing that patient experience. It's about making that patient feel special. Because patients, when they feel special, become engaged. Means they advocate for themselves. They participate in that care delivery. So this communication approach actually does that. You can use reward and recognition. That's very important for staff, especially, if they have done something that you need to recognize. This is the time to really recognize that. You can ask if anybody else in this team that has achieved something that you as a leader need to recognize that staff member as well. So this is kind of the time you would do that, okay? Thank you for choosing our clinic. It's been a privilege to care for you. Thank you for your call. Is there anything else I can do for you? I have the time. So basic. Any questions about ADET? Any questions about this? Bear in mind, this is scripted. So you actually have to go and write out your ADET. Your ADET for a colleague, your ADET for a patient or a client if you're in social services. You've got to write out your ADET. Optimize it, clean it up, share it with friends and colleagues, and perfect it. It becomes second nature. And the more you use it, the more you practice it, then you hardwire it. So I always tell people, I don't have, but you have little name tags, and you could use the back of your name tag to actually write your script. So you have access to it very quickly. But if you have a desk where you're generally sitting, please don't sit when the patient walks in or the staff member stand up, greet them, but you can write the ADET script on the desk. But have it, on a piece of paper that's on your desk. Okay, so have it close by. The more you use it, the more you practice, it becomes hardwired and eventually second nature. Remember, we will be assessing that. When we assess patient experience, when we assess staff experience, and when we round with families, we're going to ask them. We're going to ask them, was ADET used on them? Of course, in the terms of experience. So bear that in mind. Next slide. Okay, so the CAP survey is a survey that we use in the USA. I'm kind of adapting it for South Africa at the moment. And essentially, it's a survey that we administer to patients in hospital. It's a consumer assessment of healthcare systems and provider survey. That's what it means, but it's experience. We are assessing the experience. We do it while they're in hospital. Sometimes we do it immediately after they're discharged. You can see sometimes it's 48 hours or 6 weeks before that. But basically every single patient will get a survey for them to answer. And that's what we're trying to assess. We're trying to assess their experience. Okay, so it's a survey that we will roll out similarly. It's different for outpatients. It's different for inpatients. We have a policy of surveying every single patient. But it's possible for us to do that because we have a robust electronic health record system, a digital platform, so every patient is connected to us digitally. So, you know, they have the app and they receive the survey to take immediately. We can correlate at the back end the experience to clinical outcomes, etc., and we can actually pinpoint it to at the department level, floor level, organization level, etc., especially if you're in the big system. So hopefully that's what we'll start to do in South Africa. So you can start making data-driven interventions. Okay, next, what's the time, Vic?
I think that's the last slide. It's 11:40.
Okay, so HCAPS is it's another survey, and you can see the things we test for: care from the nurses, care from the doctors, provider communication, hospital environment, experiences in the hospital. Okay, when you left the hospital, was there adequate follow-up, and the overall rating. So these are the, what's it, I think it's 2, 4, 6, 9 components that we assess. And each one of those components will have 4 or 5 questions for that. Okay? Any questions?
Sorry, Prof, I missed the first part of the slide. I was a bit disconnected.
Okay, you mean the previous slide? Go back one slide, Vic. Yeah, so this is the CCAPS, the Consumer Assessment of Healthcare Providers, and then we have the HCAPS, the specific to healthcare. This is essentially where a survey that we use to assess patient experience. So we, apart from the rounding with patients, every patient also gets a survey. Okay? And the components of that survey, Vic, next slide, these are the components. So this is what we're looking at. Okay? So we're assessing in the survey the care they receive from the nurses, the care from the doctors, communication, hospital environment, their experiences in the hospital, you know, did you get help when you called for help? You know, if you made specific dietary requests, was that made? When you requested or complained about pain, did somebody respond? So those are experiences in the hospital. And then post-discharge, once you left, did somebody follow up? So we have a policy that provided the doctors need to phone every one of their patients within 24 hours of discharge. Okay? That's the rule. So when doctors come in the morning, one of the first things they do is they call the patients they've discharged the previous day. The doctors do it. Okay? It's a quick conversation. It's a scripted conversation. You know, good morning, Mrs. This. I hope you're feeling better. This is Dr. That. You know, I just wanted to follow up with you on condition A, B, C, D, E. Please let us know if there's anything we can do while you recover at home. Scripted. The doctors have the script. They have to call the patients. It's not optional. They have to call the patients. Okay? Because we ask, in the survey, we ask the patients, did you get a follow-up call within 24 hours from your physician? We ask them. Okay? Next slide. Okay, any questions about generally the concept of patient experience? Any questions? I'm going to come back and talk about ADET. I'm going to talk about managing up. And I'm going to talk about rounding again, and more specifically give you more slides, but that's the overview. So as you can see, this is not rocket science. You know the difference between patient experience, patient satisfaction. They are not the same thing. We can barely assess satisfaction, and really it's of no value to us. So I cannot understand for the life of me why we have used that in South Africa. We need to migrate towards experience. Patients who have a positive experience, remember experience is objective, measurable. Patients who have a positive experience become more engaged. In fact, they advocate for their own care. That makes them more compliant. That improves their clinical outcomes. And it makes a better business case for us. Obviously, in healthcare, with limited budgets, if patients are more compliant, you save, whether you're public sector or private sector. Okay? 3 key tools to increase that patient experience and improve that is ADET. It is a scripted communication tool. Okay? Acknowledge the patient, introduce yourself, make an effort for patients to understand the time implications, explain what's going to happen, thank them, make a promise of excellence, and please ask them what you can do further. That's script. And so that's the tool number 1. Tool number 2 is rounding. In other words, chatting to patients to get a sense of their experience and what you can do to enhance the experience. It's got nothing to do with the medical rounds. Okay? So you'll take a random sample of patients and spend a percentage of your time every single day rounding on patients, on families, and on staff. As a manager or leader, it's the single best investment you'll ever make from a time point of view. Okay? If you allocate, 40 minutes or 50 minutes of your day, diarize it and don't change it. Okay, also don't advise staff that you're going to be chatting to them for 10 minutes tomorrow and don't pitch up. Okay, so stick to that and cancel everything else, because the logic is you're prioritizing rounding, because you're using rounding to improve your patient experience and clinical outcomes and business case. So it's as important as any other meeting that you would have to attend. Okay, so rounding is important, and managing up. By now you've got a sense of, engendering confidence in patients about your organization and your staff. Always speak up and highly of them, because patients feel better, they feel more comfortable, they trust you. When they trust you, they become more engaged in their care delivery. Okay, so that's the kind of overview. We'll come back and talk about ADET and rounding, but let's take a quick lunch break so we can probably get done by 2:30 again, or even earlier. What's the time now, Vic?
11:50.
11:50. So is 25 minutes fine? Can we reconvene at 12:15, or you want a longer break? 12:20. I'll give you half an hour. Is that okay?
It's fine, but
Yeah. Get back at 12:30. Now that you have a picture, idea of what rounding is and ADET is and managing up, it'll go much faster. Okay? But in 3 hours now, you've got 3 powerful tools which you never had before. Okay, these are really powerful tools that you can use. And remember, all of this is to improve patient experience and staff experience. Bear in mind, when you talk of quality, those 2 things are important components of that. Okay, so pretty important. Okay, we'll see you back at 12:20. Enjoy your break. Okay.